Good morning, everyone. My name is Sabina Adhikari, and today I will present my Capstone project. This presentation focuses on three connected areas: cybersecurity, rural health equity, and a policy implementation. I will begin with research questions, then I will briefly explain my method using the Wald and Gilson Health Policy Framework. After that, I will present my main finding. I will discuss how AI and digital health tools create both opportunities and risks in rural health care. Finally, I will end with specific policy recommendation. About 14% of US population live in rural area, and there are about 2000 rural hospitals that serve as key access point for these communities. In rural area, the hospital is often not just one healthcare facility. It may be the main place where people receive emergency care. So when a cyber attack happens, it is not only the computer problem, it becomes the access to care problem. The slide also shows 50 billion rural health transformation program for fiscal year 2026 to 2030. This is important because it creates a major funding opportunity to strengthen rural health care infrastructure. In my recommendation, I suggest that at least 5% of this funding, or about 2.5 billion, should be set aside for cybersecurity and AI readiness. For my method, I use a retrospective qualitative policy analysis. I review the publicly available document from 2018 to 2026, and I synthesize the funding using the Wald and Gilson Health Policy Triangle. This framework helped me to organize the analysis in four parts. Content, meaning what the policy require or fund. Context, meaning why rural settings are different. Process, meaning how the policy is developed and implemented. And the actor, meaning who has the power and the responsibility. The HIPAA security rule is a federal baseline. However, rural providers often face a major implementation gap. They lack cybersecurity staff, funding, updated system, secure backup, and strong vendor oversight. The slide also shows the two important policy opportunities. Yes 2169, the Rural Hospital Cybersecurity Enhancement Act, and the Rural Health Transformation Program. Yes 2169 is important because it focuses on rural cybersecurity workforce strategy. The Rural Health Transformation Program is important because it creates a large funding stream for rural health infrastructure. This slide shows four structural barriers that make cybersecurity harder in rural healthcare setting. First is limited funding. Rural hospitals often operate on tight budget. Second is a cybersecurity workforce shortage. Third is aging infrastructure. Fourth is a broadband gap. When a broadband is weak, cybersecurity and digital health service become harder to maintain. These slides show that rural cybersecurity requires a coordinated action across the different level of government and healthcare system. At the federal level, agencies such as SSS Office for Civil Rights (CMS) and the other play the important role. They can set rule, provide funding, issue guidance, regulate technology, and support the technical assistance. At the state level, the State Office of Rural Health, Medicaid Program, and the Health Department can organize the grant, regional support hub, supporting system, and the local implementation support. At the local level, rural hospital, clinics, IT staffs, privacy officer, vendor, clinician, and the patient are responsible for putting policy into practice. The important point is that rural hospital cannot carry this responsibility alone. This slide discusses AI in the digital health governments. The California provide an useful model. AB 3030 requires disclosure when health communication is generated by AI. This means patients should be told when the information is AI generated. SB 1120 requires human oversight in healthcare decision making. This is important because AI should not replace the clinical judgment, especially when decisions affect the patient care or the insurance approval. However, this law also have a limitation. Disclosure alone may not mean that patients fully understand how AI is being used. For the rural improvement, I recommend that AI tools should be validated in rural population. Vendors should have a clear privacy and the security duty, and the patients should have appeal or audit process if AI affect their care. The first recommendation is dedicated funding. I recommend amending Yes 2169 with a 5-year rural cybersecurity implementation grant. I also recommend serving at least 5% of rural health transformation fund for the cybersecurity and AI readiness. The second recommendation is a rural specific guidance. SSS Office for Civil Rights should issue a minimum rural cybersecurity package. The third recommendation is regional support hub. The State Office of Rural Health should create a regional cybersecurity hub that can help rural hospital with the risk assessment, tabletop exercise, and the shared training. The fourth recommendation is the local governments. Each rural hospital or the clinic should create a digital health and cybersecurity governance committee. This committee should include the leadership, IT staff, privacy officer, clinician, patients, and the other committee representative and the vendor when appropriate. Overall, the recommendation is to make a rural cybersecurity practice funded and reinforceable. This slide showed a realistic 12-month implementation timeline with a responsible actor. In month 1 to 2, the focus is assessment. The hospital leadership, privacy officer, AI leader, and the state office of rural health should complex a risk assessment. In month 3 to 4, the focus is planning. The government's committees should update the policies, create a checklist, and develop a bridge response plan. In month 5 to 6, the focus is building the technical safeguard. IT staff, vendor, and a regional cybersecurity hub should implement the multi-factor authentication, endpoint, and access control. In month 7 to 8, the focus is training. Community health workers should train staff on HIPAA incidents, reporting, and AI disclosure. In month 9 to 12, the focus is testing and improvement. The government's committee and regional partners should conduct tabletop exercise, review audit log, and report remaining gap. By month 12, the expected outcome is documented risk reduction plan, train staff, and tested the business response process and a clear report of remaining gap. In conclusion, cybersecurity is a part of rural health equity. The first takeaway is that the rural rules are necessary, but they are not sufficient. HIPAA provide an important baseline, but rural healthcare setting need implementation capacity. The second takeaway is that the biggest barrier is operational capacity. Rural hospitals need funding, workforce support, infrastructure, broadband, and vendor oversight. The third takeaway is that the policy should be equally centered. Protecting cybersecurity also means protecting the privacy, continuity of care, and patient trust in rural health community. My recommendation policy package include dedicated grant funding, rural HIPAA guidance, regional support hub, and AI governance with local oversight. Overall, rural health databases are not only the technical problem, they are public health and health equity problem. These timelines show how US rural health policy from 2023 to 2026 increasingly connected cybersecurity funding, infrastructure, and workforce support to strengthen rural healthcare system. Thank you for your time and attention. I welcome any questions.